So when we talk about chronic ischemia, this is often on patients who are possibly already known to your service, and they will normally complain of what we call intermittent claudication. Claudication really means to limp, and this occurs intermittently, particularly when they exert themselves. The key issue for me as a clinician is that this is a reproducible phenomenon. It occurs at the same period of time each time the patient walks. So if a patient walks from their house, they often get to a landmark such as a shop or a postal box, and that's when they have to rest up before they can proceed onwards. If a patient describes that they get pain one day at 100 yards, next day at 5 yards, next day at 2 miles, to me this is unlikely to be related to their blood vessels. It's relieved by rest and is associated with an ankle-brachial indices of less than 0.9. So we look at critical ischemia. This is where you've got progression of disease which can lead to rest pain with tissue loss and superimposed infection or gangrene. They often require regular analgesia, which is often opioid based, for greater than 2 weeks, and is associated with very poor blood flow to the lower extremities with an ankle-brachial pressure indices of less than 0.3. This is a threat to the patient for their long-term limb survival. So when we talk about pain within the patient when they come to your clinic, well, you want to look at a number of things, and I always remember SRIDOC: site, radiation, intensity, duration, onset, and character. And for the patient with claudication, this can cause pain in the calf, thigh, or buttock, depending on the area of disease in the patient's blood vessels. The disease generally radiates from below to superior, and it increases as the patient walks and settles during rest. It is crampy in nature. There are a number of precipitating factors and alleviating factors, but generally it's exertion and rest are the two exponents of these two issues, and patients often deteriorate with time. Additional information: I really want to know how far my patient walks. So I can accept that they have peripheral arterial disease. I can accept that they have an occlusion in one of their blood vessels. But if that patient, through their own adaptation, can walk for over 30 minutes in one go, I will probably not wish to rush to intervention for that patient, unless they've got tissue loss due to a different portion of disease in their lower extremity. But generally, a patient who has good walking threshold would not require any intervention. It's also important to know what stops walking, and I personally ask each of my clinics how they feel when they walk up a hill, or how they feel if they're running after a bus. And most patients that get to see me in clinic struggle with those two factors. A lot of patients will then say, well, I struggle walking up flights of stairs. It catches me the minute I walk up the first 2 steps. To me, that's suspicious that it's maybe not an arterial related issue. So, patients should not be sore in the first few steps. If a patient tells you that they're immediately sore at rest, sitting, lying, or whenever they're just getting up to stand, that to me worries me that it's not related to arterial insufficiency. There's no need to sit or lie down to relieve the pain. It can occur all the time. Again, this worries me for arterial insufficiency being not the primary diagnosis. So when we look at rest pain, well, people say, oh, I get pain in my legs at night and my legs fidget a lot and they feel hot and sweaty. That's not vascular rest pain due to a severe reduction in blood supply. Vascular rest pain is essentially a boring, gnawing, awful severe pain that just is terrible. It keeps the patient up at night, they're fidgeting, they have to get up and walk, and this is classically in the dorsum of the foot and toes. It doesn't usually extend proximal to the malleolar region. Patients often have to lie with their limb hanging out of the bed, and that's because whenever they get into bed, a number of factors happen physiologically. They rest, so their effective pulse rate reduces, so that reduces circulating blood volume, and that can reduce their perfusion in an already diseased limb. There's an element of vasodilation whenever they get into a nice warm bed, and also they lose the effect of gravity as they're lying supine rather than standing. There are a number of other factors that patients can come up with whenever they present with difficulty walking. A lot of patients can have a problem with their back. They may have a previous history of trauma, they may always have had a bad back, or they may have a very large body mass index that does put added stress on their major bones. These symptoms often cause discomfort radiating down the leg, and that normally occurs in the lateral side and can classically occur at standing, sitting, lying, at various different movements, and may not be necessarily related to exercise. Patients can have osteoarthritis of their hip that radiates distally, and again, when you examine that clinically, often you can get discomfort when you actively and passively move the hip in internal and external rotation. Cauda equina is very interesting. Cauda equina is essentially entrapment of the spinal canal, putting pressure in the spinal cord that can cause irreversible damage and even paraplegia. However, cauda equina can be related to compression by a prolapsed disc, but in patients with aortoiliac disease, when they exercise, they get an effective drop due to reduction in lumbar artery perfusion, and that in itself leads to ischemia of the distal spinal cord, and that can lead to a vascular cauda equina. Again, this is something that's quite a challenge even for me in the clinical environment to elicit when a patient attends. There are other various rare factors that happen where people can get pain in their anterior compartment, particularly when they're younger. On a previous publication in the Ulster Medical Journal that I was fortunate to be involved with in 2011 delineates a number of differential diagnoses for patients who can present with lower limb exertional symptomatology. When we look at cardiovascular risk factors, well, there's a number of things that we can't do anything about. These are constitutional risk factors. Male sex. However, it's important to realise that when female patients get peripheral arterial disease, it often presents at a more advanced stage. As you get older, blood vessels deteriorate, and we all have a family history, particularly with low genetic drift in Northern Ireland. There's also a deletion polymorphism in the ACE2 gene that is related to the renin-angiotensin system that increases risk as well, but this is quite rare. Hard risk factors are risk factors that are scientifically proven to cause deterioration of blood vessels. This includes hypertension, hypercholesterolemia, nicotine intake, and also blood glucose homeostasis abnormalities, diabetes. Soft risk factors are associated with peripheral arterial disease, and this is a sedentary lifestyle, obesity, and also stress.